5210. Every kid, every day. Let's have fun the healthy way. 1, 2, 3, 4, 5 servings of fruit and veggies are great to eat. 1, 2 hours of playtime or less on our screens is more than plenty. Let's go play outside. 1 hour. Tiger it, my turn to hide. 0 sugary drinks. Yeah, that's the healthy way to think. Every kid, every day. Let's have fun the healthy way. 5, 4, 3, 2, 1.
Hey, well, I'm Jessie Kreiner, and I am so excited to welcome everyone to today's first episode of Project Echo for Pediatric Obesity, Our Kids' Health by the Numbers. I'm here with Keys for Healthy Kids, and for anyone who's unfamiliar with us, we are a grant-funded nonprofit on a mission to make the healthy choice the easy choice for kids, families, and communities across West Virginia. Intro song today is newly released 5210. We partnered with JJN Multimedia on it, and it turned out amazing. And it's an earworm, and it will live in your head. So if you'd like to see that again sometime, check out www.keysforhealthykids.org/5210. All right, and with all of that housekeeping, I'm going to go ahead and turn it over to our host today.
Hello, I'm Miranda Strickland, the clinical coordinator for Keys for Healthy Kids. I'm so excited that you guys are able to be here with us today. We have a guest, Dr. Jeffrey. Most of you know her, but she is the medical director for Healthy Kids Wellness and Weight Management Program and the director for Keys for Healthy Kids, and is an expert in pediatric obesity. So we're really happy to have you today, Dr. Jeffrey.
Thanks so much.
By the end of this session, you should be able to compare obesity prevalence and trends between West Virginia state data and national level data. You should be able to describe the effects of social determinants of health in West Virginia on pediatric obesity. And you should be able to recognize that the pediatric obesity epidemic is an emerging health threat to West Virginia youth. So without further ado, let's go in and start talking about the obesity prevalence and trends between West Virginia state data and national level data. And I think it would be a great place to start at state of childhood obesity.
Yes.
Dr. Jeffrey.
Yes,
so
and that's kind of our go-to place that we look for the latest number. So there, it's from state of obesity, but the last several years, they morphed that into state of childhood obesity. So you just Google state of childhood obesity, and you can, that's where all this data that I'm getting ready to go over for our child's health by the numbers is going to come from. The data there is from NHANES, which is the National Health and Nutrition Examination Survey that's done every 2 years. And it is a combination of questions for kids and families with actual measurements, which is a little bit different than some of the CDC data that we often talk about with the BRFSS or the Behavioral Risk Factor Surveillance System, which is just a questionnaire. I don't know about you guys, but I weigh a little bit more than I state on my driver's license, just saying. But we have longitudinal data from both of those data sources. And what I really want to focus on is not as much the prevalence right now, even though that's important, is I think that we need to look at trends. And that's not only with our conversation as pediatricians and childhood experts, but also in with our public health colleagues as well. So the trend is also important when you have a patient in front of you, just so that you do not focus as much on that weight and train them to focus on weight, that we focus more on health and health behaviors when we have that patient and family in front of us. So national pediatric numbers, the number is, drum roll please, 2 to 19 years. The current prevalence is 19.3%. When we think about the trend, however, the trend is that our pediatric obesity numbers the elevated BMI over the 95th percentile, which is the definition of pediatric obesity, is 19.3%. That has increased over threefold over the last decade. I mean, name another disease that has increased in incidence 3 times over our lifetime. It hasn't happened. But it seems like the urgency of that is not there. So I always make it a little bit more urgent than maybe it is because of that. It like blows me away. It's not more urgent. As far as we said, we were going to compare the national with West Virginia, right? So as far as West Virginia, that number in our high school students are 22.9%. The curve mirrors, it's not stable like most other states in the nation. West Virginia's adult curve is kind of going like this. So, which is increased, continues to increase a little bit every year. That's how our high school and middle school curves are also progressing. But there is some good news that I want to share. I don't want to be all gloom and doom. I want us to be able to walk away with something and feeling like that we have a role to play in impacting these numbers. So I guess, again, we want to focus on the behaviors, right?
Yeah, so what behaviors do you think are
associated with an elevated BMI? So the behaviors, that's where we get into the BRFSS that we talked about before. Now, these are, the surveys are given to the high school students. So this, again, is on the State of Childhood Obesity website. And the first one I want to give is one that's improving, and that is high soda consumption, which now is at 27.9%, and that is actually declining in West Virginia, high schoolers and adults. Woo!
Wonderful.
So shout out to all the partners. I see Kristen McCartney. Shout out to all the partners that have that we have been just so proud to work with on the Rethink Your Drink campaign. There's actually even a website out there, Rethink Your Drink WV.
So what is Rethink Your Drink?
Rethink Your Drink.
For those who don't know, I don't know if everybody knows what Rethink Your Drink
Rethink Your Drink. Drink milk and water. Milk with meals, water whenever. Get a filling station, a water filling station in your school. It's great for COVID. You'll drink more water. You've just got to get your school principal to allow you to carry around a water filling station. Actually, there's a policy in the legislature right now that will have any new or renovated construction include a water filling station from American Heart Association. So one good win. A stat that bothers me is the amount of kids that don't eat breakfast is 16.2%. And that's with the majority of schools in West Virginia offering, well, most of the schools offering breakfast, either a set down breakfast, a grab or go. So to know that our kids still aren't eating breakfast when that's available is a little bit concerning. Now, one we've worked on that I could just beat my head against the wall is our low fruit and vegetable consumption. They're 10% for the low fruit and vegetable consumption, and the vegetable consumption is 9.8%. Yeah. And we've worked tirelessly, especially again with a lot of the partners that we see on this call, with increasing the availability, not just telling and educating ourselves and our parents and the West Virginia community at large to eat more fruits and vegetables, but really making them available so that they're available wherever the kids and families are. And that's kind of that public health policy systems and environmental approach that we use.
So what about physical activity?
Okay, I'm glad that you brought that up. Again, this is something that's really surprising because of some of our stronger laws at the Department of Ed with PE, and that everybody's required to have PE unless they do an exemption. Maybe that exemption needs to go away. And also policy 2510 that that requires a school to do 30 minutes of physical activity outside of PE, like recess or any rules for the older kids or what have you. But our low PE participation is 72.6%. I mean, uncalled for. Our high school students that are physically active at least 60 minutes a day, only 26.3%. Yeah. So then that leads us also to screen time, right? Like we played in our mantra, and we just kicked off this big 5, 2, 1, 0. We've talked about the 5 fruit and vegetable servings. The 2 is the screen time, and high computer usage is 41.7%, and high TV watching is 20.8%. Again, all of these are available at our State Department of Ed through the BRFSS and on the State of Childhood Obesity website.
So what about the younger age groups? You told us about the high schoolers. What can you tell us about younger kids?
Okay, so another good, like, yay, finally we have some good news. News wasn't so great back in 2014 when they did a new study with the WIC population that they're also doing every 2 years like they do with NHANES. And it's kids aged 2 to 4 that participate in WIC. So they're already considered low income. I think WIC requirements at that time was 185% above the poverty line. So the criteria is actually easier than qualifying for Medicaid or what have you. It's dependent, just like SNAP or supplemental nutrition program is based on your family size and income. So the overall rates from 2010 to 2018 for the states went from 15.9% of BMI over the 95th percentile or an elevated BMI to 14.4%. So it went down, right?
Yeah.
West Virginia, unfortunately, we're lagging behind. In 2014, our number was 14.4%, which was the low part of the national data. And unfortunately, it shot up to 2016 to 16.6%. And I was personally devastated because Keys has really worked in that early care and education space to really, really hone in on the earlier kids when they're developing their habits. The earlier, the better, so we say, and that's so important with the brain development. You also are developing your nutrition likes and dislikes and taste preferences during that time. The good news is, though, since 2014 and that upswing, it was 16.6, 16.4, and 16.5. So we have stayed stable. It looks like a straight line on that graph. And as everybody knows, in personal weight loss, you first maintain and then you decrease. So I'm really excited and hope that we see some further decreases in our younger kids.
Yeah, that would be wonderful.
Yes,
so,
definitely.
We used to think that we didn't have to worry about younger kids who were overweight, and we called it baby fat.
So, we did, and it's okay, right?
Yeah, they're gonna grow out of
it. It's baby fat, yeah. They're 10 years
true?
old. They're 10 years old, and it's still that baby fat, right? Yeah, we hear that, and big boned. We hear a bunch of that. But one of the research that has spoke to me so much over my career has been the Bogalusa Heart Study. And this is a longitudinal database. There's been tons of research that has come out of that database. One study looked at 2,610 children, ages 2 to 17, followed them for about 17.6 years until they were at the age of 18 to 37 years. And they looked at BMI and skin fold thickness. And we're not even going to get into that as far as we can maybe do that in the chat. Maybe another day. But this was between 73 and 96, really kind of in the middle of that upswing and the increase in an elevated BMI for our kids. And the take-home message for Bogalusa was that there are 2 times that are most predictive of weight status, predicting obesity in adulthood linked to chronic diseases. And those chronic diseases, we all know, that's like hypertension, heart disease, early heart attack, sleep apnea, diabetes, prediabetes, fatty liver disease, all those things. We did find that 77% of overweight children remained overweight in adult. Wow. The 2 periods that were most reflective and most predictive of that were where we know, right, was 12 to 14. not 15 to 17 like we were always taught. We were always taught before puberty, don't worry about it. And that couldn't be the furthest from the truth now, okay? It was 12 to 14 years and 2 to 5 years. Wow. Okay? 2 to 5. So we really have to, as providers, treat early, as public health professionals, make sure that we're not blowing that off as baby fat. When we're in the office, we need to watch that trend, and that trend, especially between that 2 to 5 years. We all know that that BMI curve dips, and if our kids are above the chart during that dip, which is when our kids are absolutely the leanest, instead of them following that growth chart and kind of being parallel to that, their weight increases, the weight gain each year increases exponentially. So that's a big risk factor.
You keep talking about BMI instead of weight. That's really what I hear you keep saying. Why is that?
Okay, so there have been studies that have done with patients, focus groups, to ask how they would prefer their provider to talk about their weight, BMI, or overweight or obesity. And no matter what, we know that obesity is a disease. I mean, as early as 2008, the Obesity Medical Association, and then in 2013, the American Medical Association classified obesity as a chronic disease. But when I say obesity, I say overweight. We have an image in our mind of not only a larger size, but lazy, and that it's their fault. And there's that blame and stigma that's automatically associated with it. Mm-hmm. So I've been trying to not only even say weight, but just an elevated BMI, because that's what's removed from the kids and family. Obviously, you have to educate them on what that is. And I go over that BMI trend. So we take that focus away from weight. And now I've actually even just been saying growth. Let's look at your growth chart, see how you're growing. And I think it makes a big difference with the conversations that I'm able to have with my patients, or in a community meeting or something along those lines. What we say makes a difference. There's just so much stigma associated with having an elevated BMI. There sure is.
So do you have any other data for us about West Virginia? So
West Virginia is one of the few states that does measure data, and we have more data in real time. And that's the Cardiac Project, which was started by Dr. Neal, one of my mentors, in 1998. And it soon after that became statewide. And the advantage of cardiac numbers is that we do measure them ourselves in our schools. Cardiac is now supported as a subcontractor through the SNAP Ed program that's led by Kristen McCartney and Gina Wood at Family Nutrition Program. So, but the real-time data with cardiac, I'm going to give you the longitudinal data that we know with fifth graders, 28.4%, which is much higher than the numbers that we're getting from NHANES, had a BMI over the 95th percentile, which is in the obese classification, as we talked about. An additional 18.7% were in the overweight category. Those numbers are much higher than what we were getting in our national databases. Okay, so that's something to be taken to heart. The second part of that in cardiac before, when they were measuring the lipids, is 25% of those kids had abnormal lipids. Okay, so again, obesity is a disease. It comes with comorbidities. If our children are suffering from weight issues and those comorbidities early in life, the future health is not looking good for them, and we need to intervene now.
All right. Do you have anything else to say about the obesity prevalence, or do we want to go to questions?
Let me see. Let me look at my notes here real quick and see if there's anything else. One other thing that I don't often talk about, but our legislators are interested in when we're trying to make an impact at the policy level, is that the cost of obesity as a disease currently for children, and children don't carry a high cost in comparison to adult, and this is healthcare cost, is that the cost is 14 billion with a B like
Wow.
ball, of direct healthcare cost. Okay, so when we're actually advocating for some policies to help our children be healthier, we have to remember that the price tag has a lot to do with that. We, with the Bureau of Public Health, when Jessica Wright was at the helm, we did a study with Harvard Prevention Research Center in the CHOICES, CHOICES project. And we did find it's a cost effectiveness study, and they're looking at what interventions can we do to fight pediatric obesity that are going to lead to the biggest decreases in healthcare cost, which the biggest decreases in healthcare costs. And there are 2 or 3 that really ranked a lot higher than the other ones. Do you know what the number one was? Do you know?
Sugar drinks.
I put you on the spot and you passed. Way to go. It actually is related to sugar drinks, and it was a sugar drink tax of at least 1 cent per ounce. And that actually had the biggest investment use of our money, and it not only decreased sugary beverage use, and they're having wonderful data with obesity rates in Mexico that they have done that, but it also decreased the healthcare cost the most, and you're also generating revenue that we would hope that would go back into public health programs that further worked on policy and systems change for our kids. So I think that's all. I think I went through all my numbers. Yeah. The only other thing that I would bring up is about those child nutrition policies, which have a lot to do with those numbers. West Virginia's child nutrition policies have been strong. Like when Healthy Hunger Kids Free Act came out, West Virginia was an early adopter of those policies. And that's when we tried to do more scratch cooking. We went to 100% whole grains. Fruits and vegetables fruits and vegetables were offered with every meal. You know, there are a lot of changes that have really shown really good results. I just don't understand why that's not happening for us in West Virginia. So that's really it. Right. Jesse, we've been going 23 minutes. So do we have time for questions, or do we have any questions in the chat box?
We don't actually currently have any questions. So.
Oh, you guys, you're letting me down. It's okay.
I guess she answered everything.
Yeah, this was really by the numbers. Probably the majority of people knew at least the trends of the numbers, but I think it's good for us to revisit that every now and then. And this is going to set the stage for the rest of the topics that will be happening in this Pediatric Echo series.
Oh, we do have a question now.
Okay.
The question is, if you could have one policy wish list to pass in the next 5 years, what would it be?
Sugar sweetened beverage tax at 2 cents per ounce.
And she didn't even hesitate.
You know.
Yep. I think we haven't figured out about the fruits and vegetables. And we'll talk a little bit about that in segment 2, which we'll have a part 1 and a part 2 for when we convert this into a podcast. So they're 30-minute segments. And I think we're going to discuss that a lot more in part 2. But great question. There definitely isn't a silver bullet, but if there is one, that's definitely it.
All right. Well, on that note.
Mary Emmett is raising her hand.
Oh, Mary, if you could put your question in the chat, that would be amazing. But I can go ahead and try to unmute you for now. Mary, go ahead.
Jessie loves the control of keeping everybody muted.
But you are unmuted now, Dr. Emmett, if you want to go ahead and ask your question.
I will. I hated not being able to see people, and I hated, you had me all discombobulated today.
That's on me. I'm so sorry. I'm a control freak. It is what it is.
Where can we put some more focus? You know, you mentioned the one policy thing about an additional tax on beverages, etc. But what else can we do? I mean, this is like moving a rock up a hill.
It is, isn't it? I think it's going to be in collaboration, Dr. Emmett. If we look at any social problem, whether it's structural racism, whether it's poverty, if we look at anything, it's going to take action at every level, right? It makes me think of the socio-ecological model, where we've too long focused on the individual and not focused on the environment or the policies out here that affect the environment. So my second thing would be, definitely working more together, doing a collective impact approach so that we are really chipping away at this from every level. That would be my number one answer. My second answer would be that we've got to improve our food system. Like, our food system is getting worse instead of better. You know, now our grocery stores are 80% ultra processed food. I mean, there's no food in them that was grown in the ground. You know, God didn't grow that food. It's we don't even know what it is. And the longer that goes on, the more we're going to continue to see these metabolic disease earlier and more severe. But of course, that's tackling big business, which is not very popular. It's tackling the big business industry, which most of their CEOs came from tobacco. So they know that playbook, but we also know that playbook. We just need to put it into action and making sure that we're covering every base.
Well, it also means helping people to, I just think that we don't, as families, we don't plan well enough so that we anticipate what our week's going to be like. You know, obviously you can't eliminate all the chaos in your life, but
yeah. And hasn't that gotten so much better during COVID?
You can eliminate, yeah, I mean, by planning ahead, you can plan some meals, you can have them ready, you can put them in the refrigerator, you can put them in the deep freeze, whatever. You can plan ahead so you don't have to buy the prepackaged stuff off the grocery store. You can let it sit there and expire.
Yep, but it takes more time planning. It doesn't necessarily have to take more money. Our SNAP-Ed partners are the ones that are great to show us how to do that.
Yeah.
So you're preaching to the choir, and thank you for all your support that you've given me and Keys for Healthy Kids over the past 10 years. I appreciate you.
I just think we need to, it's a whole system that's
absolutely
bring up.
Absolutely. And in the next segment, I would like to talk, we have to cut this segment off to meet the podcast guidelines, but I would like to talk about a framework that we've been working through with Miranda's Clinical Community Collaborative. We didn't really have that on the agenda, but we'll squeeze it in there somewhere.
Yeah.
Okay, Jessie.
All right, on that note, this concludes part 1 of today's episode. If you're joining us live in real time, we're going to roll directly into part 2, so don't go anywhere. If you're joining us via podcast at a later date, you are welcome to continue right on to the next one or check it out the next time you've got time. And welcome back, everyone, to part 2 of Project Echo for Pediatric Obesity. Today is our very first episode, and it's Our Kids' Health by the Numbers. During part 1, which we recommend you listen to first, we broke down a lot of those numbers, talking about national to state level comparisons, data that's available on stateofchildhoodobesity.org, etc. So we're here today with Miranda and Dr. Jamie Jeffrey to talk a little bit more about Health by the Numbers.
Hello, everyone. We're so glad you've joined us again. So we are going to talk about the effects of the social determinants of health in West Virginia on pediatric obesity. So I think a good place to start would be, what is social determinants of health, Dr. Jeffrey? Can you explain that to us?
Sure. I like to think about the social determinants of health of the environment where we live, learn, work, play, and pray. okay? And the policies and systems that affect that environment. This, some people say, it's your zip code. It's where you live, because all those things that we mentioned, live, learn, work, eat, play, and pray, are determined by your zip code. And we know in multiple research studies how it's been borne out in lots of communities that in a 2-mile radius, the mortality rate may be 8 to 10% higher across the track, so to speak. And that's a walking distance away. And how can that be? And that's based on those social determinants of health. There are multiple different models from different folks. The one I like the best is from the University of Wisconsin and their social determinants of health. Some people call it population health. Have it broken down. Now the providers on the line aren't going to like this. I didn't like it in the beginning, but it actually has that if you look at the social determinants of health, the effect of health outcomes, okay, how well our kids and families do with health outcomes, that would be measuring that BMI and looking at that BMI trend, the blood pressure trend, your hemoglobin A1C, whatever you're measuring to follow that chronic disease, that healthcare comprises 20% of that impact. That's in comparison to the socioeconomic factors of 40%. Again, those things that are determined by your zip code, determined by your educational level, your employment level, your income and your family income, the social supports that you get, transportation, housing, all those things that are determined by your zip code are included in those socioeconomic factors. That comprises 40%. Then we have our health behaviors that comprise 30%. But again, those health behaviors are determined by those socioeconomic factors. So they're very intertwined and integrated. 10% is actually the physical environment. And in the physical environment, that's really, you know, access to the transportation, to parks, to sidewalks, and things of that nature. Does that help?
Yes.
Okay.
Yes, that makes very clear.
Okay.
So what about, why is West Virginia lagging behind in the improvement of health for our kids and families? Why is it that we're behind?
Geez. So I grovel with that question all the time. As I look at our past grant reports and I look at the things that we've done in West Virginia, I look at our strong child nutrition policies. I look at state of childhood obesity, and there are 10 things there, and we have 8 of the 10 checked. Why is that? And I think it's boiling down to our poverty level determined by the social determinants of health. And I don't know the answer, but by golly, we got to figure it out. We've got to figure it out for our kids and for our future generations. And I'm not sure what we need to do that, but we need to get better at it. Like I said, there have been some areas that we've moved the needle in those behaviors, like those sugary drinks, which I think are huge. That's a huge win. But there's still so much that we want to do. Like I said, definitely the access to fruits and vegetables is one of the areas that we need to work on, that we've worked on forever. We haven't seen as much of a needle move in those behaviors, though. So it boils down to our environment and the policies that dictate that. And I think we can't get ahead because of our poverty level. I mean, I think I have to do one thing.
So what can you say about the poverty rates in West Virginia? Speaking about numbers.
Speaking about numbers. Okay. Well, first of all, as pediatricians, we all know the effect of poverty. So let's first talk about and put that into perspective, that as pediatricians and providers of kids and families and the parents out there, we talk about early development and early exposures and why that's so important. And that's because this is the time period when our brains are making connections. If they don't make connections, then you have a certain time period. We often talk about those first 1,000 days. So if there is poverty during especially the 0 to 3 age, we know that it's proven that there are poor health outcomes, poor mental health outcomes, definitely our overall development, which later leads to educational outcomes, which leads to job, income, all those other things that we talked about related to social determinants of health, that those are all affected. So the poverty nationwide, from the Census Bureau, the last numbers that I saw, which were before COVID, mind you, was about 16%. And that was West Virginia, sorry, that's West Virginia numbers, was about 16%. That's about 4 points higher than the national average at 12%, which ranks West Virginia about 6 out of the 50 states. The bad news, though, is that the child poverty level is about 19.6%. And we can kind of become, I don't want to say gruff to those numbers, but what I want you to think about is that 67,507 kids. Wow. Let me say that again. There are 67,507 kids in West Virginia that live in childhood poverty. That number is worse since COVID. We're the 7th highest in the nation. So just think about our future related to the social determinants of health that I was listening to before. That sounds very bleak. It's almost depressing, but we can't let that get us down. We've got to let that make us fight harder for our kids. We've got to go into action to improve this, okay? That correlates to a higher number for children, as I said, also women, also communities of color, and also our senior citizens. So our most vulnerable become more vulnerable. Sounds like I didn't say that right. The median income from West Virginia currently is the 2nd lowest in the nation, which is why I say I think that poverty is really one of the things that are holding us down, so that we really do need to look at these economic booster programs. One of the things I love is supporting the local ag, all the farm to school, farm to table, farm to ECE, farm to everybody, Farmers Markets Association, Food and Farm. This is a real opportunity for West Virginia to make an impact in increasing the availability of fruits and vegetables, but also helping bring our families out of poverty and providing food for themselves. The median income was $48,850 in 2019, and that was almost 17,000 below the national average. So, and also we worry about how poverty leads to food insecurity, and that relationship to all the habits associated with food. It does get a bit overwhelming. But
so what can you tell us about food insecurity?
Like the numbers of food insecurity? Mm-hmm. I guess we are talking about by the numbers. So, so with the food insecurity, now some people, families and kids that live in poverty, suffer food insecurity. Some don't, because of where they are at the poverty line or up to 185th percentile of the poverty line, they may be participating in federal food subsidy programs that keep them from being food insecure. Okay, so they're not, those terms, poverty and food insecurity, are not mutually inclusive. Food insecurity leads overall to food anxiety. And I see this in a lot of my patients. And the food anxiety is like worrying, when are we going to run out of food or not have enough food, so that when we have food, I'm going to overeat. And when we don't have as much food, I'm going to restrict. And then I've got to restrict because there's no food. So it's just this yo-yo effect of overeating, almost to the point of binging, to going hungry. And that's one of the things, of course, we can't fathom, right? That our kids are hungry, and how that affects their sleeping cycle, their learning in school, and everything else about them. That's kind of one of the Maslow's rights and the base of the pyramid, that we have to eat, we have to have food and sleep. So besides the food anxiety, obviously decreased nutritional quality. One of the things Dr. Emmett was talking about earlier is the shopping and the preparing. And I think that when you add on that stress of poverty and that food insecurity, it's almost like how we've been in COVID, that we just feel like our mind is spinning, and that vulnerable population feels like that all the time. So you don't have the executive functioning to do that planning. And that's where a lot of our efforts need to be targeted.
Yeah, education.
Yeah, absolutely. And like I mentioned, the highly processed foods, if you don't have a car and you're shopping at the corner store, or it's cheaper and a lot easier to drive through fast food, you know, whatever, these are the things that our kids are getting, those highly processed, ultra processed foods that aren't really food in my mind. And they're going to be very calorie dense, but very low in nutritional quality overall. So those are some of the things that happen with food insecurity. West Virginia rates is anywhere between 14 to 16, depending on if you listen to somebody local, the Census Bureau, USDA, or what have you. But we're sort of around that. Definitely it's increased during COVID, probably to the 17 to 19% rate. And that's even with additional support, like the summer PEBT card that I know, like we got in Kanawha County, and a lot of the counties had, if they had community eligibility option, which are most of the counties. Amanda Harrison, the food service director, we're talking about how close we are to being near, you know, we're in the 98th percentile, whatever. There's only a few counties that don't have community eligibility option. And one of the legislation that was regionally talked about, which was Build Back Better, did actually have policies in there for universal school meals, which is a huge policy target that included breakfast and lunch, maybe even adding a supper, and also the summer benefit for kids, like replacing or adding on to the summer feeding program.
So can you give us an example? Do you have a case maybe of somebody that their environment influenced them and affected their health?
Yeah, so one of my favorites. Could you tell that was planned, guys? Oh, we're so slick. So my favorite is my patient, Deshaun, and he was actually one of my early patients. I took care of him when Healthy Kids was still located at Children's Medicine Center at Women and Children's Hospital. And he participated in our group where he came weekly for 8 weeks. And he did make a lot of strides. Like, one of the things that I remember is that he did stop drinking sugary drinks during that time period. He did increase his outdoor play and limited his video time. But this was a case where Deshaun was on the west side of Charleston. He had gotten his bike stolen. He had been bullied by kids down the street that mom was pretty sure was mixed up with drugs. So mom was actually happy that he was addicted to his Xbox and that he would come home from school, stay inside, play his Xbox, because she knew he would be safe. Again, safety is one of those bases of the foundation of Maslow's hierarchy of needs. So that behavior led to decreased physical activity, increased game time, and he drank his soda and ate his chips while he was playing his video game. So needless to say, his BMI was out of control, which led to uncontrollable hypertension. He actually was on 3 hypertension medications when I saw him at the age of 14. Okay. He did do pretty well during group. We saw him back. We hadn't seen him in like 4 months. So I was really worried, but he came back for his follow-up, and he had a huge drop in his BMI. I was so proud, because when I have that lag, you know, they're either doing really well or they're not doing well at all. So we were so happy for him, because we really had rooted him on. He was such a sweet kid. Come to find out, it's because they moved from the west side to South Charleston. He now had a sidewalk. The sidewalk led to a cemetery, and he was playing hide and seek with his friends in the cemetery and riding his bike all over the place. So it was really that increased physical activity time, the decreased screen time, which he wasn't snacking on those chips and drinking that soda. And he had a huge improvement. And it was because he moved from the west side of Charleston to South Charleston. That's a great reflection of how that environment affected him. And that environment change did more than I could ever do for him as a provider, even though I was seeing him weekly. Very powerful. It's almost like, you know, that flower I gave you for your year anniversary being with Keys? Yeah, so it used to be green. It's still green, it's just a different green. It's not that deep, beautiful green. It's this lime green that's kind of like a fluorescent marker. So when Miranda's plant stopped growing, we didn't blame the plant, and we didn't blame the plant's mama. or grandmama. We didn't blame the plant. We said, what do we need to do to this plant's environment to get it to grow again? So we moved it across the room so it wasn't going to be frozen by the window. We watered it, gave it some fertilizer, poofed up its soil, and guess what? It's happier. It's standing straight up. Its leaves aren't like this. The color hasn't exactly improved. So why would we do that for a flower? Yet when we see our families, there's all that stigma, again, and judgment that we talked about being associated with obesity before. We also have that happen when we're talking about these social determinants of health, right? Like what burns me more than anything is when I hear people say, well, they just need to go get a job. Well, don't you think? Yeah, is it that easy? And it's not. And we've got to start being more empathetic and understanding that. Again, it comes down to meeting our patients where they are and helping them on that social support end to be able to maneuver the system, I guess is one way of saying it.
Yeah, very good. So can you explain, we keep hearing that the pediatric obesity epidemic is an emerging public health threat to West Virginia youth. That is a bold statement. So do you agree with that? And why are we saying that?
Definitely, I agree with it. And I think that it got some attention during, with Michelle Obama's Let's Move campaign. There's definitely been a lot of snide remarks regarding to that, but at least the initiative was on the stove. We may not have still been on the front burner of the stove, but we are on the stove. We are off the stove, people. And hopefully one of the good things that happens with COVID, because the obesity rates and a lot of the things we've been talking about have been a lot worse with COVID. And I would like to talk about that as a twindemic, right? The pediatric obesity and COVID. But again, tell me what has increased by threefold in the last decade? What other disease has done that? Is there been? No, there's not. And it's one of the most common. Actually, the most common is dental caries. I hope Gina Sharps is on here. So, okay. I agree 100%. I think I even said it in the beginning that we can't let this happen. We've got to do something for our kids. We've got to figure out how to move the needle on health overall. And it's got to start with those different behaviors, just like we talked about sugary drinks. We've got to do better at collaborating and covering all bases from policies to systems and really working on improving our environment.
So we are in the middle of a pandemic. Did you guys know that?
Yeah.
It's only been around for 2 years. We wonder if it's ever going to end.
Yes.
But so tell us, what impact has it had on childhood obesity?
Definitely, I had some numbers written down and I was just looking for them and I couldn't find them, but everything has been exacerbated. So anything related to childhood obesity, everything has been made worse, which again is surprising because of all the federal funding that has come down to really help and try to fill in those gaps. Does that make sense? Mm-hmm. That number one shows how bad COVID has been. And we talked about the changes of COVID with the family, right? Disrupted routines, that uncertainty that you mentioned, how long is it going to last, the effect of kids, virtual school versus not virtual school, all the sports activities and group activities being canceled, the kids staying at home in isolation. It just has wreaked havoc on our routines that have affected our health choices. I've had a few families that have done better because of this, very few though. The majority have seen a significant increase in the body mass index, and they know it. They know it, and they can tell me exactly why that is, which I think is great that they can identify that and have the insight to do that. But it really is that family effect as well. There have been 2 studies out for pediatric obesity from CDC and Kaiser that both show that it has increased. Some of the most alarming numbers are that adults with obesity, specifically a BMI over 40, have a doubled risk of dying. Double. They double the risk of dying from COVID.
And why is that? What do you think?
Obesity is a disease. I mean, it's a disease of chronic inflammation. We've got to go back to that pathophysiology and the chronic disease nature. One of the biggest things that we see with the metabolism of children and adults with obesity versus normal weight individual is that altered physiology, metabolism, and that chronic inflammation. So then when we get COVID, we have an exaggerated immune response, okay, which further escalates that immune response. So think about the MIS-C disease in kids. So we know that that's also an increase. We haven't seen the death rates as much go up as with adults, thank goodness, but it's just that state of chronic inflammation, and not to mention the respiratory compromise that we get with some obstructive lung disease because of the nature of the build of adults with that carry more weight. Yeah, so it's a disease, and it's an underlying disease state that's been the most predictive for poor outcomes, for mortality and morbidity. So hopefully, one of the things we can do is allow COVID to open up this conversation again, to talk about how we need to get to the root causes and all come together again, work collaboratively at every level to make sure that we are addressing this epidemic.
So in closing, I see we're getting close to being out of time, and I know we have some questions. So I just wanted to ask you, how do you've mentioned some things, but just is there anything else that you think that we can move the needle, ways that we can move the needle in West Virginia with this problem?
So I think that I answered that as far as with Dr. Emmett's question before. I think that one thing, definitely using the chronic disease framework that was published by Dietz, which we can give everybody access to, where that we really are having some tight connections between the kids and families and the clinical care and the community, so that we're all interconnected and we all know what each other's doing so that we can support that child and their family. We're currently doing a 5210 prescription program and using that prescription as a tool to refer these families to physical activity, cooking classes, and all those type of things, which help alter that behavior, but actually showing how to do that. And we're going to get into a lot of those discussions in the future echoes. I guess the last thing I would say, especially for the providers, because I know I've ranted a lot about the numbers, and I think the numbers are important, but I don't want anybody to get frustrated to go, she didn't tell me anything I didn't know, and I don't know anything to do any different. So I'm going to leave you with one word. Number one, join something outside of your practice that is an initiative in your community that helps your children, whether it's working at a food bank, a child care center, a school, what have you. What is it that you can do to help directly in your community? What you can do in your provider office is definitely during these times and always screen for food insecurity. And there is a toolkit called the Hunger Vital Sign, which is 2 questions that you ask. This was developed by the American Academy of Pediatrics and FRAC, which is the Food Research and Action Center. And it prepares you for how to do this. It gives you those 2 questions for screening, and it gives you information on how to intervene. In West Virginia, we have the 211 number. So until you're familiar with local social supports, then you just tell your patient to call 211. And I would even mention that even if they don't screen positive, because I know that I've had families that are food insecure because of my prior discussions with them and making their goal settings, that they answer not true to both those questions so sometimes they hesitate to do that. So again, meet your parents where they are. You have 211 to refer them to, and that's a good place to start until you build up your known community sources in your local community around your practice and schools.
Thank you so much, Dr. Jeffrey, for being here today. We really enjoy the wonderful insight that you have given us about this problem. And we'll go over to you, Jessie. Do we have any questions?
We do actually have a question.
Okay.
Right. So Jump Rope for Heart, walks to support various disabilities, etc., used to be a common annual occurrence many years ago. Is this something that is still promoted in our schools? Obviously, COVID would complicate efforts, but maybe brainstorming similar programs would be beneficial.
So Jump Rope for Hearts is American Heart Association initiative. And I am aware of physical education teachers that still do that. I do not know if it is a statewide effort like it was in the past. So I know in the past that the State Board of Education, the coordinator during that time had helped more schools do it. I definitely haven't heard as much, but that's an example of a wonderful initiative because it increases awareness. Just like Go Red for Women, which is coming up in February. So everybody get ready to wear their red, terry white. And it also is increasing physical activity for kids, and it's jump rope. So jump ropes are a portable physical activity equipment that's very cheap, easy to replicate and replace if they get broken. So it's a win-win for everyone. So I think that would be a wonderful idea for us to look into. So thank you.
And I would add, as a former teacher, this is my wheelhouse a little bit, if you have interest in those things or you're familiar with them, work with the local schools in your communities. A lot of the time at this point, they're pulled in so many different directions that they're barely flying straight at this point. So if you're able to, come in, lend a hand, help set it up, take the burden off, it would be fantastic. So if you're looking for some kind of volunteer work or something like that. We have an additional question. Do we have time for it, Dr. Jeffrey?
Yeah, go ahead.
I always have time. I don't know about the podcast criteria of 30 minutes, but shoot.
Right. All right. So what do you do when you have families with food insecurities? How are the food packs doing with healthy food options?
How are who doing?
She said food packs.
Food banks.
Maybe the backpacks or the snack bags or the
food banks.
Food banks. Okay. Food banks. Thank you.
It has gotten tons better. So I will say that. I'm going to save the backpack programs. I'm going to save the backpack programs. Yeah, let's go into the food banks. There are certain, definitely, some of the food banks have hooked up with farmers. They've hooked up with grocery stores and are offering much more fresh produce than they had in the past. There have been a lot of grants available for them for cold storage so that they were able to do that. Still, the majority of what they order have to be shelf stable, which is very difficult to get to be healthy, but you can, okay? So instead of buying ramen noodles, buy whole grain spaghetti, right? Instead of buying the spaghetti sauce that is the national spaghetti sauce, buy Kroger brand or Muir, M-U-I-R, which does not start with high fructose corn syrup like the others do. So just how you would shop for your family and buying the items that you would want your family to eat, provide those to the food banks. It's a very controversial topic, but especially with food insecure families, those highly processed foods are going to raise your blood sugar faster, going to increase your insulin faster. That's going to lead to more of that metabolic dysregulation and your chance of prediabetes and metabolic syndrome. So we really do need to look at to make sure that we're not only offering the fresh fruits and vegetables, but also high fiber products like beans, okay? And protein sources, which tuna and canned chicken, those, we have lists that we can provide for folks that are providing this to have healthier options that are going to be a lot healthier as far as the ultra processed foods, especially related to insulin resistance, metabolic syndrome, diabetes, and what have you. And we have those lists available in multiple places.
And like Dr. Jeffrey said too, families can call 211 to get information. The food banks do have some food distribution sites where they're doing it. I know in Smithers, they're actually doing a food distribution monthly for families. So there are those opportunities, but 211 can give families all of that information. So, and we're actually we are out of time, actually, not just about, we're out.
And I'm just going to real quickly say about backpacks. When you're asking for donations for backpacks, you want to give a list and say, these are the items that we put in the backpacks. I've had my patients bring me their backpack, and it is essentially ramen noodles, Gatorade, or soda. And it would be better for them to be hungry. And I know people are going to be, oh my God, I can't believe she said that. But really, we've got to look at that, because we definitely can do better in that area. It has gotten better. We have moved the needle in that direction, definitely, but we still need to do better than we are.
And real quick, for Portia, you asked a question about a breakdown of children in poverty by county. There is a place called County Health Rankings, and you can actually put in your zip code and county, and a lot of times it will give you the numbers. So I know that that's one place to go for that. I think they do have Kanawha County in there. And also there is information, usually is it with, Kristen has it, this Food Link has it, yes.
Yeah.
So yeah, you can find out some information on there too. Those are places that you can go to find out the poverty rates for specific counties.
And again, if for the providers, you just want to tell them to call 211, because
Yes.
that's easy and they can do that. Some of the other websites are a little bit harder to maneuver. So
yeah.
But
if you're looking for data, you can go to FoodLink.
And we're going to have all these topics covered in more depth in our webinars that are coming up. So,
or in the future, or you want another way to reach out to us, use www.facebook.com/keys4 healthy kids.
5210. Every kid, every day. Let's have fun the healthy way. 1, 2, 3, 4, 5 servings of fruit and veggies are great to eat. 1, 2 hours of playtime or less on our screens is more than plenty. Let's go play outside. 1 hour. Tiger it, my turn to hide. 0 sugary drinks. Yeah, that's the healthy way to think. Every kid, every day. Let's have fun the healthy way.
All right, bye everybody.
Bye everybody.
bye everybody. Thanks for joining.